good afternoon, ladies and gentlemen. My name is Lesley Regan. I'm the chair of Wellbeing of Women, the charity that researches all aspects of women's healthcare and also is very engaged in education and advocacy for good health in women. We're going to have our webinar this month focused on gynecological cancers because September 2024 is Gynaecological Cancer Awareness Month. So we like to move with the times. And we've got two very, very lovely guests here. Sbba Siddique, who's a 55-year-old lady, she's just been telling me, with 3 children and a very successful Bollywood radio business. And she's going to share with us her experiences. And in particular, she's going to talk about something that's very dear to my heart, which is the inequalities that often cross across Asian and South Asian women's healthcare. Not just inequalities that you may think in their access to it, but also in the way that their communities deal with it. So I'm giving you a little bit of, for instance, there. Now, Neil Ryan is a great friend of mine, and he's been a very great loyal supporter to Wellbeing of Women and has sat on our scientific advisory committee for some time. And he is now a lecturer, or are you a senior lecturer? You're a lecturer, aren't you, at Edinburgh University? And he is one of the RCOG subspecialty trainees in Gynaecological oncology, which means gynecological cancers. And I know that he's going to absolutely amaze you or wow you, since it's Wellbeing of Women, with all of his knowledge and his commitment to helping women understand what they can do to help themselves, as well as forwarding the science and the understanding of gynecological cancers. So without much more ado, I think that what we should do is remind you that the webinar is being recorded, and we're very happy for you to use the chat function for comments and questions. We are going to have some time at the end to try and address some of your questions. And because I'm trying to do the impossible at the moment, which is keep an eye on the chat and engage with Neil and Sbba, I will be relying on Lena and the WOW team in the background to feed me questions or give me nudges about the topics that have perhaps come up most. Now, I suppose there's no woman that I've ever met who's not worried about getting gynecological cancer because, well, the boys can't get it, can they? So it's something that we've got to deal with ourselves. And I'm going to now pass over, I think, to Sbba, because I don't want to waste any more time talking to our audience. I want them to really benefit from our 2 experts, the patient perspective expert and the clinician. And so Sbba is very kindly going to share her story, and it's very trendy terminology at the moment, isn't it? With the lived experience of being a woman with a gynecological cancer, which it took her a long time to understand was a problem. And she still, I think, is asking herself, well, you know, why are women not better informed about the symptoms and the signs that they should be looking out for? So over to you, Sbba. You're going to start with telling us your journey and the treatment and how you were affected and the impact it had on everyone around you. Let's start with that. And then when you've helped us with that, then I'll go on to the other things that we wanted to talk about the Asian community and some of the taboos that we've collectively got to climb over if we're going to make this a much safer world in terms of medical care for women. Over to you, Sbba.
Thank you, Dame Lesley. It's a pleasure to be here. Thank you so much for the invitation. So I came at cancer with 0 knowledge, with 0 history in the family, and in actually trying to get diagnosed, it took me over 6 months. I started to feel unwell back in October of 2021. And I was just, I didn't have any sort of like sticking out symptoms. I was just putting on a lot of weight. I needed to pee a little bit more. And I was generally feeling unwell. I was going back and forth with my GP, and this was for 6 months, where he kept telling me, Mrs. Siddique, you're a woman of a certain age. It's just menopause. It's just menopause. But inherently, I knew something wasn't right. By sort of like December time, by Christmas, my tummy had really bloated, and I literally looked like I was 6 months pregnant. In the new year of 2022, I coincidentally had an appointment with my dermatologist, who at the end of the consult looked at me and said, Sbba, have you had your stomach checked out? And I said, yeah, I've been talking to my GP. He's just saying it's menopause. She said, no, it's not menopause. Your stomach is distended. Get yourself an appointment, get yourself looked at. Now, I don't think if she hadn't pushed me that I would have actually gone back to my GP. I would have just believed what my GP was telling me, because after all, he's the expert. I didn't have any sticking out symptoms, and there wasn't anything stark apart from the fact that I'd been piling on the pounds and my tummy was just bloated. So I went back, they did some bloods, and the bloods came back with the CA125 raised. They did an ultrasound, again, that came back with a growth. We then had some more blood tests. We had another ultrasound, an internal one, which was rather unpleasant. We then had a CT scan and an MRI. And from a system that had kind of like delayed things for over 6 months, within the space of 10 days, you know, I saw the very worst and the very best of the NHS. In 10 days, I was given a diagnosis of suspected ovarian cancer. My world fell apart because I hadn't had any first-hand experience. I'd had a few close friends that had gone through it, but when you have somebody within the family and you walk closely on that journey, that does give you a little bit more of an insight on what you might anticipate or expect. But what I was then about to go through, I had never dreamt of in my wildest dreams. My world turned upside down. I was then referred to, my oncology team is at Wexham, which is my local hospital, and I was referred for surgery at Hammersmith. And it was information overload in a really short space of time, and I wasn't equipped to be able to deal with that or cope with that, because I had no idea on what ovarian cancer was. I didn't know what to expect or what may be the treatment pathway that I was going to have to follow. When I had my oncology consultation, they had given me the options that, look, would you like to go for surgery first, or would you like chemo? My logical brain said, you know, actually, I want it out. Let's get it out as quickly as possible. And so I was scheduled for surgery in April of 2022. I was bumped because there was a far more urgent case. And at the end of April, I finally had my first surgery. When the surgeons opened up, they found that the cancer had spread, and literally all that ended up happening was that they removed the ascites and they closed back up. At that point, I didn't understand. I couldn't understand. I had been through so much in building myself up for such major surgery, because the surgeon had told me it's going to involve full debulking, everything is going, and, you know, it's been major surgery. I had mentally prepared myself for that. But when they opened up and closed back up and did absolutely nothing, I couldn't comprehend that. I did when I came around from the anesthetic and the morphine, which were giving me hallucinations, and I was just in a very bad place mentally because of all of that. I finally did understand. My surgeon was absolutely amazing. It's Professor Christina Fotopoulou. She's leading in her field. She is the most wonderful human. And when her team explained it, when she explained it, I understood why they didn't continue, because if they had, it could have compromised my quality of life, because it had spread to the bowel, which could have meant that I would need a stoma. So she took the decision to stop. Let's go for chemo, and then we will try again. I then embarked on IV chemo, which chucked absolutely everything at me. After 4 cycles, scans showed that it hadn't really touched it. By this time, my biopsies had come back, and they discovered that it was low-grade serous ovarian cancer, and therefore the IV wouldn't have really helped. Options were getting fewer and fewer, and the world was getting darker and darker. But my oncology team, as I say, are absolutely brilliant. My oncologist is Professor Marcia Hall, and she said, look, let's try oral chemo. Now, if I had thought that the side effects from IV chemo were going to bash me, oral chemo took the life out of me. It's a 1-a-day tablet, and it is the major side effect of it was a skin rash. Now, I'm quite a logical person. I like to know, I like to feel empowered, and I like to know what's going on in my care. I tried to search the internet. And I learned to be very sensible on where I searched. There was no looking at Google, just Google. I'd go to the NHS website. I'd go to the Macmillan website. I'd go to the NICE website. So I'm looking at reputable sites, and I found nothing on what that side effect from that medication would do to South Asian skin. I found lots of pictures on what that rash would look like on Caucasian skin, but nothing, not even on the manufacturer's website. So I was going into the unknown. And I think had I known at the outset what I would then have to endure, I probably wouldn't have taken it. But that's another story for another day. I took the medication, and the reaction was I was on it for 7 weeks. It physically and mentally broke me. I reached a point where my skin shed from head to toe. What started off as just sort of like teenage acne on my face grew and just exponentially was all over my body. In the space of 7 weeks, I was hospitalized 4 times with what the A&E doctors diagnosed as what an acid burn victim would experience. The rash was from head to toe. I came off it after 7 weeks, had a scan, but it was dark. Those 7 weeks towards the end, the last 3 weeks were very dark, where I reached a stage that treatment had bashed me so much that I wanted to end. I wanted it to all end. I wanted life to end. I wanted treatment to end. But as soon as I came off the meds, that got better. I saw glimmers, I saw hope, and I had taken counseling as well. And that is what helped me and pulled me through. The good flip side, it had done enough to shrink the tumors, and I went back for my second surgery in February of 2023. And I had the best of news from my surgical team that they had managed to get it all. At that point, I was 100% tumor free with no residual disease. But the journey itself was a roller coaster, both physically and emotionally. It took me to some very dark places, which I wish no other patient to have to go to, because there is just insufficient evidence on certain treatments, their side effects, and how they affect people of different ethnicities. And that, for me, was a huge challenge to try and mentally overcome. But that played a big part in also shaping the work that I do sort of like now post NED, in that I don't want that experience to be the experience of other South Asian women. So I advocate for more awareness about our own bodies. I mean, I didn't understand until I actually got my ovarian cancer diagnosis that my cervical smear didn't pick up for anything else but cervical cancer. And looking back in hindsight, that's shocking, because I'm a woman in my 50s. I should have known that, but I didn't. The impact of all of that isn't just on the patient. It's not just on you who is going through treatment. There is a huge ripple effect on the family. And when there is a ripple effect on every single relationship, the relationship I had with my children, the relationship I had with my husband and I run our own business. That impacted our business because all of a sudden 50% of the workforce is not there. And it is a struggle for family to watch their loved one go through something so difficult and so traumatic. Counseling helped me through that because it gave me ways to compartmentalize what I had experienced and gone through, and to be able to process it in a healthy way. But watching my family, it was the hardest thing I'd ever had to do. When I was at my very lowest through the rash was all over. It would drain me, because what was actually happening was that because my skin was trying to repair so quickly, it was drawing heat from internal organs, or my internal organs, which ended up meaning that I would shiver, I would shake, and I wouldn't be shivering and shaking for like 5 minutes, 10 minutes. It would be 4 or 5 hours until I reached a point where I would pass out, because I was just so exhausted. And my family having to sit and watch me do that was awful, because I could see the pain in their eyes. And there were days when I would say, I'm okay, I'm fine, I'm doing really good, I'm having a good day, when they could physically actually see that it was the entire opposite. But it took for me having to take that medication for it to be able to shrink the tumor, for my surgeon to be able to operate. So I acknowledge that I had to go through that process to get the outcome that I did. Another thing that played a huge role in my well-being through all of my treatment was my faith. I'm a Muslim by faith, and I have a very spiritual and very strong connection with my faith. And that is what sustained me. It grounded me. You know, the mercy and the blessings that I got through treatment, but also the love that of family and friends that surrounded me. Without that, I don't know how I would have got through things.
It's a heart-rending story, isn't it? And you tell it so eloquently and so generously, sharing all of those dark, fine moments, which must have been very, very difficult. And I can fully understand, having had my own cancer journeys, how distressing it is for the people around you. They're really agitated, and I suspect you tried to hide some of it, didn't you? Because you want to try and protect them. We always, particularly our children, we always
Absolutely. Absolutely. I was quite fortunate. My children are older, and what I insisted from the beginning was I included them on my journey with every step of the way, every appointment. They knew what was happening for me, because when those dark moments came, it transpired that it was a good thing that I had done that, because they became my biggest advocates when I couldn't advocate for myself, but they also became my biggest cheerleaders, pulling me out of very dark places.
Yes, lovely, beautifully put. I quite agree. And you must be very proud of your children and everything they've done. And they're very proud of their mum, I'm sure, because it goes two ways, the admiration fan club, I can tell you. So tell me a little bit more, though, about the problems that you had, particularly the skin problem. And did you then subsequently find that this was a particular side effect for women who are Asian?
The rash is one of the major side effects of the medication. I don't know if I'm allowed to mention it, but it's trametinib, which has now been licensed for, first line defense against ovarian cancer, but it wasn't at the point when I was given it. And so the lack of information around the results of all of that it impacted me hugely, because, as I say, those 7 weeks were the weeks from hell. And hindsight's a great thing, and had I known what I was about to encounter, because how dark it actually got, how physically and mentally it drained me, I think I would have had a very, very difficult time deciding whether to take it or not. And I think I may not have taken it. But then, on the flip side, that was what shrunk the tumor to be able to get me to a place where, Professor Fotopoulou was willing to actually perform surgery again, because it was so far widely spread. I mean, I think when she finished surgery, it had gone to the appendix, the duodenum, it had gone to the bowel. So it's a cheeky bugger that had spread absolutely everywhere.
Yeah. And she is a very meticulous surgeon, I know, because we
Amazing.
work in the same institution, and I similarly have great admiration for her as well. And her ability to still laugh about things,
yes,
which is great, and to laugh with her patients. She's a very good all-round doctor, as well as being a very talented surgeon. So I'm now going to pass over to Neil Ryan, who, as I say, is one of our leading lights. He's a trainee still, but he's incredibly knowledgeable. And he's going to answer all those very difficult questions about what are gynae cancers and what are the 5 types of gynecological cancers and the prevalence and who is at risk. So he's going to start off with that. And I think he's very kindly made some slides to share with us. So can I invite you, Neil, to take over, share your slides and give us the whistle-stop tour through a topic that I know you're very knowledgeable about.
Thank you very much, Dame Lesley, and no pressure whatsoever with that introduction. Sbba, thank you so much for sharing that. That was deeply moving and powerful. And I think what I want to sort of go through in a very quick way, but in a way that I hope has boiled down the key elements that enable people actually to think to themselves when they have a moment and they pause, is this normal? Am I okay? And what do I need to do? And I think the other thing that's really important, we've talked about the importance of family, about that wider network, about that support. These are symptoms that we need to recognize within ourselves, but they're also symptoms we need to recognize in our loved ones and feel the ability to say to somebody, that's not normal. You need to go and get that checked. The other thing that I think we're going to talk about, but I feel very strongly about as well, is that you know you know your body. It's not for anyone else to tell you what's going on. And I think if you're worried about something, you need to persist until you get someone to take it seriously. And often those people aren't trying not to take it seriously. Everyone's got competing pressures. Everyone's got different things on their desk, but you've got to feel that you can advocate for yourself. And as Sbba said, you know, once the symptoms were recognized, once the system started, it worked extremely fast. So we just need to get through to that point when things really do. And I see it all the time, the NHS working incredibly well and absolutely focused on delivering the best care it can. Anyway, some slides. We all love a slide. We all love a PowerPoint. Here we go. We're going to go from that very moving and emotional time to some slides. So I think the key thing is, as I've sort of alluded to, that knowledge is power. You know, these aren't symptoms that are meant to scare us. They're not symptoms that are meant to be things that we hide from. They're not symptoms that we should put away in a box and deal with tomorrow. You know, the whole point of this is that if we know, we can do something about it. And if we can do something about it, we can get it sorted. And that's the key bit. And as Sbba's really highlighted really clearly, that the earlier and the quicker that we get in, the more treatment options and the less radical they are, and hopefully the less toxic they are. So we've got to get in early. And the way that we can do that is knowing what things should trigger us to go and see our GP and what things we should be persistent about as well. So I thought I'd do it we've got a few to cover. Female gynecological anatomy is unbelievably amazing. And unfortunately, as a side effect of that, it can develop cancers that are also unbelievably amazing. So I thought I'd go with the most common and work my way through. So the first is cancers of the womb. They are the most common in the United Kingdom. They are on an ever-increasing instance. What I mean by that is they're getting more and more common. We're seeing a lot more of them. We're seeing them at younger ages. We're seeing them in women who have lots of comorbidities and medical issues, which sometimes means that routine treatment is very difficult in those women. We're also beginning to understand a lot more about genetic causes. So we're beginning to see women with womb cancers that actually, when you take their family history, there's a really clear history in there of cancers of the bowel, of the ovary, of the wombs. They're called Lynch syndrome. And actually, we could have got in early and stopped that cancer. So having that awareness of your family history is also really important too. Does your family have a cancer history? And is that cancer history persistent throughout the generations, throughout one side of the family? And if so, go and see your GP to discuss that too. Okay, so what are the things that should alert us to there potentially being a womb cancer developing? Well, the first really is bleeding. The symptom that we know as doctors to treat very seriously is if a woman starts bleeding after the menopause. Now, that's become slightly more complicated as HRT has become more common, which is a great thing. But obviously HRT can lead to some bleeding, and that does mean that it's hard sometimes to tease apart if the HRT causing the issue or if indeed there is a change going on in the lining of the womb. But that's for your doctor to work out. You go and see your doctor. If you've got bleeding, even if you're on HRT, you go and see your doctor. It's for us to work out why that is. This symptom is so predictive of a womb cancer that we know that if someone turns up with bleeding after the menopause, that we should get them seen in hospital rapidly. So this is probably a symptom you're not going to have too many issues with getting referred into the hospital with. Now, not all women, obviously, with this symptom have womb cancer. There's many reasons why you can have that symptom. But we do know that we need to triage those women quickly and get them into the hospital. The ones that are less known about are this sort of vague vaginal discharge. And again, this can be after the menopause. It can be in between your periods if you're still having periods. And it can be bloodstained. It may not be bloodstained, but it's different. It's new. It's not quite right. Again, that's something I want you to go and get checked out. The others are a bit more sort of vague, and they're symptoms, again, that can be caused by an array of different things. But if they are persistent and they're going on and they're new, they should be checked out. Pain and cramping in the lower tummy, that definitely needs to be looked into if it's going on for a while. Difficulty urinating or going for a wee more often, or blood in the wee, or just something not quite right about having a pee. Again, go and get that checked out. Lots of reasons it can happen, lots of simple tests that can be done in primary care, lots of ways in which we can investigate that thoroughly. And then pain after sex. You know, it shouldn't be painful after sex, especially if that pain is new and sudden. And it's getting worse, it's staying the same, it's not going away. And for women who are having periods as well, it's really important to know what your periods are for you and what normal periods are for you. And if they have started to change, they're getting heavier, they're getting more painful, you've got bleeding between your periods, all of these things are not normal. And they need to be investigated by your doctor or by your clinician. And again, lots of things we can do to try and work out what's causing it. Most of the time it's not cancer, but we do need to find those women in whom it is cancer. Ovarian cancer, so we've heard about Sbba's story, and it's unfortunately a very common story in which women will go and see their GP and they have symptoms that are unfortunately symptoms that you can get with lots of different conditions. And just to, I suppose, get the GP's perspective, a GP in a busy practice is probably going to diagnose maybe 1 or 2 ovarian cancers throughout their entire career. So they're only going to see 1 or 2 ovarian cancers. It's easy for me, who sees an ovarian, who is my entire specialty is built around treating ovarian cancer. It is very hard for them to work out who needs urgent referral and who actually these symptoms could be something else. And that's why you do need to advocate for yourself, because only you will know the persistence, the degree of symptoms, and the worry it's causing you. Ovarian cancers are unfortunately also on the rise. We're seeing around about 7,500 of them a year in the United Kingdom, and that number goes up each year. And the problem that we have with ovarian cancer, unlike endometrial cancer or womb cancers, is that the symptoms that are associated with it are very non-specific. They are symptoms that we see in lots of different conditions that are not ovarian cancer. So abdominal bloating. Lots of reasons you have abdominal bloating, but again, if it's persistent, if it's new, and if you're over the age of 45, that is odd. And that should warrant further investigation. And there are simple investigations that can be ordered to rule out, or at least very much remarkably reduce the likelihood of you having an ovarian cancer, such as the CA125 that we've heard about, and also an ultrasound scan. Abdominal pain, again, lots of reasons why you can have pain, but if it's persistent, new, and it's different for you, go and see someone, get it checked out. Often with this bloating, you just don't feel like you can eat, and your appetite goes off, and you're feeling full all the time. You might be feeling sick, you might be nauseous. Again, that's not normal. Let's get that checked out. And then again, it's these other symptoms around bowel habit and having a wee. So if you're going for a wee lots more, if your bowel habit's completely changed or is just different for you, again, these are symptoms that we need to be aware of. And they're symptoms that should prompt you, if they're persistent, to get these simple baseline tests in primary care to see what's going on. Now, there's a nice little acronym that helps us remember these, which is BEAT. And the reason that we brought in this acronym is because we want to, well, first of all, beat ovarian cancer. But secondly, it's because we need to be reminding ourselves that if you've got this constellation of symptoms, or some of these symptoms not normal, needs to be investigated. And the thing that I always remember is that anyone with new onset IBS type symptoms, irritable bowel syndrome symptoms, over the age of 45 needs to be investigated as if they've got a malignancy, a cancer within inside their tummy urgently, because it's not normal. And you can say that to your GP. You can say, is it normal to get these symptoms after 45 straight away? And the other thing that you can do is you can help your GP by, you can have a look yourself at the NICE guidance. You can have a look at the guidelines that are out there. They're all available. They're all published. And if you look through those and you find something where it says you should be doing this, you can help the GP sometimes by pointing them towards guidance that's been nationally recognised. And this is something that we do recognise, that if you have BEAT symptoms, you need a blood test to CA125, you need an ultrasound scan. Okay, cervical cancer. So we're fortunate to have a cervical cancer screening program. And the idea of that cervical cancer screening program is to pick up cervical cancers way before they're a cancer. So to pick up the precancerous lesions that will turn into a cancer in a small minority of women if left untreated. That's why it's so important to engage with your smear test. But as Sbba has pointed out, that it is only really about cervical cancer. That smear test is not picking up endometrial cancers. It's not designed to, and it's not picking up ovarian cancers, and it's not picking up other cancers. Cervical cancer, thankfully, is going down, although we are seeing it's sort of static at the moment. We hopefully will start to see it go down as the effects of vaccination comes in for the generations that have been vaccinated. But obviously, if you weren't in one of those generations like myself, although I don't have a cervix, but that's probably not helpful to use me as an example. But if you haven't had those vaccinations, obviously you don't have the protection that those vaccinations deliver. Even if you've had the vaccinations, you need to continue with your smear test until that national guidance changes, because it's very important as we work out what the vaccinations are doing that we continue with a practice that we know works. So go and get your smear test regardless of your age, regardless of your vaccination status. What are the symptoms of cervical cancer? So again, it's really around bleeding in between your periods, bleeding after sex, really heavy periods, bleeding that's just out of the normal for you. If you are getting those symptoms, that you need to have someone look at your cervix, and that needs to happen soon. Now, the GPs can look, and if they're not sure what they're seeing, then they can often ask for a second opinion from us. So it just needs a visualization of the cervix to see what's going on. The other thing that you can have is, again, this discharge. And I think people don't take discharge very seriously. Vaginal discharge that's new onset, different, and persistent is something that needs to be investigated. It's not normal. Pain, again, pain after sex. These are symptoms that are a common theme here and should always be triggering you to go and see your GP. And again, back pain. So any of those things, go and see your GP. And if you haven't had your smear test, please, 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 please go and have it. Vulval cancer. So the vulva is really the outside part of the female genitalia. Vulval cancer is rarer, so about 1,300 cases every year. It's on the outside, so actually often we can see physical signs of the cancer. It's not where the cervix is or the womb is or the ovaries, which are very difficult for an individual to assess themselves. It's really important that you feel that you can check yourself. So using a mirror and having a look at your vulva, knowing what your normal anatomy is, knowing when that is changing, taking seriously symptoms like continuous burning or itching, pain that's new and in a specific area, noticing lumps and bumps, and again, bleeding and discharge. All of these things are not normal. They need to be checked. And again, if you can't visualize your vulva, then your GP is someone that can obviously look at that for you and with a more expert eye and try and work out if you need to get things be seen in the hospital, biopsied, and what happens thereafter. Vaginal cancer is one of the rarest gynecological cancers, around about 1,000 cases in the United Kingdom. So actually in a specialist centre like where I work, we don't see many of these a year, maybe 3. So it is very rare. Again, obviously the vagina is easier to access than the cervix. You can feel inside the vagina yourself and feel for lumps, bumps, and changes. But again, these cancers tend to present with pain, bleeding, discharge, painful intercourse, and again, that discharge is really important. Something has changed. It's new, it's persistent, it's offensive, it's got blood in it, it's not normal. Get your GP to see you urgently. And again, the vagina is something that we can examine with a degree of relative ease within primary care, so we can get a visualization of what's going on, and then that can prompt onward referral. I have also mentioned gestational trophoblastic disease, which is a disease associated with an abnormal change in the placenta. It is one of the gynecological cancers. I put it in there because I don't want it to be forgotten. It's extremely rare, and it happens in about 1 in 50,000 pregnancies, and it's often detected during the normal follow-up that you'd get in your pregnancy. But just be aware, again, if you are having extreme sickness in early pregnancy, extreme nausea, hyperemesis gravidum, then it's very important that you go and see your obstetrician or your gynecologist, and they will start the appropriate investigation. So just to be mindful of that for people who are pregnant too. So I think the summary is really important. Basically, if you don't feel right, if it's persistent, go and see your GP. If you find that you've got advice which is go away and it's all right, it's fine, but it continues on, go and see them again. And do feel like you can go and look at the resources that help us make decisions as well. It's not they're not closed books, they're not secrets. This isn't Hogwarts. They're on the internet. Go and look at the NICE guidance, go and look at the decision tools, go and look at what we're looking at, and just say, hold on, I've got this, this, and this. So according to this, I should have this. And that's sometimes helpful because the GP's got to know everything. I can't stress to you how difficult it is being a general practitioner. So sometimes it's extremely helpful for someone to bring that and go, I think my symptoms mean I do need this investigation. So they can go, oh, right, okay, yeah, absolutely, I can see that now, thank you. And remember, new onset IBS, irritable bowel symptoms, over the age of 45, they must be treated as if there is something going on that isn't IBS, i.e. is there a cancer causing these symptoms, that they have to be investigated in that line. So those are my slides. I hope that's a quick romp through all the different things there.
Well, Neil, that was a real tour de force, and thank you, because it's not easy, I know, and there's lots and lots of questions that are coming up for you, so you probably want a few moments to skim some of those. But I think that your comment about IBS, so irritable bowel syndrome, or any sort of tummy problems over the age of 45 is a really clear, simple take-home message. And I think that our audience will get that very, very clearly. Now, there's a comment here about from a lady who tells us that she's 49, and she says, she's been told that taking the contraceptive pill can protect her from ovarian cancer if taken for a long period of time. So I'm going to answer that. She says, should I consider taking it to lower my risk? And I say, well, not really, because I think, Neil, correct me if I'm wrong, that the risks of ovarian cancer are reduced by the pill because it stops the woman ovulating. So by the age of 49, I think she's probably done the majority of her ovulating anyway. So that's not the answer, but possibly if you've got IBS, and this is Rachel asking us, then go along to your GP and ask them and tell them that you've been hearing that you need to, that you would like to be screened for this. Now, Sbba, I'd like to talk to you a little bit more about, you mentioned very clearly that you had additional difficulties in getting to grips with the topic because of taboos within your community, within the Asian or possibly within the Muslim community. So would you like to unravel that for us, and if you feel prepared to share with us what the taboos are and how you've gone about changing it, because I know that's something that you've been quite passionate about when I've met and spoken to you.
Yeah, for sure. I wouldn't just limit it to the Muslim community. It is a South Asian thing. Cancer is still considered quite a taboo subject. It's not talked about, it's not discussed, it's brushed under the carpet. When you start talking about anything that's below the waist, and that's whether that's male or female, so it could be, you know, any of the 5 cancers that Neil's talked about, prostate cancer, anything below the waist, it's taboo because sexuality is never, or anything to do with the sex organs is never discussed. It's always a very shameful thing, and it's something that's supposed to be kept hidden, kept quiet. But even from a cancer-specific lens, cancer is not discussed for a number of reasons, because there is fear, there's mistrust. This fear that if people find out that the mum has had breast cancer or a gynae cancer, well, that may be passed down to the daughters. So, you know, people who are looking to prospectively get married, they may not want to marry them because of the risk. But coming back to something that Neil mentioned very early on in his slides, was this whole thing of, you know, looking at family history and looking at genetics and looking at Lynch syndrome and things like that. That was one of the first things that I was asked on my initial gynae appointment, that is there a history of cancer in the family? I immediately said no, not because I knew definitively whether there was or not, but because we just never talked about it. And so therefore, any future conversation about genetic testing was just completely shut down. And it was never asked again. So that's another real negative, because I've got 2 daughters, and I now that I know what I know, well, that's a real important topic for me. But also things like, you know, clinical trials. There isn't enough data on how medications and their side effects will impact marginalized communities, ethnic minorities, and, you know, people from South Asian and BAME communities. And that really needs to change. So a lot of the work that I do is really around all of this area. I am not just here or with the work that I'm doing to bash the NHS, because I think the NHS is absolutely amazing. It is working, it is stretched, and it is working with its hands tied behind its back. The staff are amazing. They do amazing things. They treat people with respect and with humility at a point when they are very, very in a really dark and difficult place. I have a lot of love for the NHS. It's government funding that it needs. It needs more than plasters, and it needs consistent and sustained funding. But as a woman of color and, you know, from South Asian heritage, I also challenge my own community for all the negative and the taboos and the stigmas that they hold, because that really needs to change. We need to be open, and we need to be having these common conversations, normalizing these conversations, because when we do that, that's when we are going to be able to advocate, give women the knowledge to be able to advocate for themselves. And Neil was right, knowledge is power. And I say that so often in the talks that I give and the conversations that I have, because when you are able to advocate for yourself, you're empowering yourself to be able to make decisions about your own health, and not leaving that at the peril of you know, somebody, another member of the family or a partner. We need to be able to have the freedom to be able to make these decisions ourselves.
That's really helpful. Thank you. Neil, do you want to make any comment about that? I mean, do you think it's really important that as clinicians we recognize that there will be some areas that are difficult to get to understand because of cultural taboos, such as the one that Sbba has been talking about the family history, for example?
I mean, I think it is vital that we know our patients as well as we possibly can, and all of the stuff that they're coming to us with. You know, nobody is without so many influences pushing down upon them at the time that they're also going through what is probably the worst experience of their life, as they're being investigated for cancer and going through invasive procedures that they don't understand, that are painful and that are scary, and ultimately getting results that are life-changing and shattering. And on top of that, they're carrying everything else. They're carrying their family, they're carrying the idea of themselves that's held by maybe their community, and the issues that they also face in the fact that sometimes the biology of cancer is different depending on what ethnicity you're from. And that for so long, women of non-white origins and backgrounds have been silent in the trial data. So clinicians really struggle to understand so much around the care that they deliver in women who aren't Caucasian, and in women who are often not middle class, because those tend to be the people that take part in studies, what the impact's going to be on them, because we just don't have that voice within the information that informs us, which is awful, which is I mean, it's disgusting. There's no other word for it. It's absolutely disgusting. We need to do so much better in ensuring that everybody's included in research and everybody benefits from being part of that, and that our data doesn't just speak to white middle class women. Exactly. Or white middle class men, which again is what you see within, you know, other specialties, and often just white middle class men and no women. One of the things, you know, for endometrial cancer, we've now know that actually women who are from sort of Afro-Caribbean background, they have a propensity for a slightly different womb cancer, which might actually mean that some of the tests that we do aren't as sensitive as we think they are. You know, these little nuances, these little things that we're just only learning now as we start to tease apart the data and look back on these things. And there's some incredible people working in this space, really trying to address this. And what is so crucial is that we remember our prejudices and our biases as doctors.
And the unconscious ones that we have, even if we think we're being very equitable to everybody, we will, unconsciously, we will have biases. It's really important. And Sbba is nodding as well, because I'm sure she has biases about white women and white men that look like you and I, Neil, because, you know, we all do. That is the human condition, isn't it? You told us right at the beginning, very helpfully, that the incidence of uterine cancer was going up, and we know a lot about that, don't we? Because we know about the you know, some of it due to HRT, only a small amount though, if looked after properly, and also the obesity epidemic that's hitting us. But there are several questions about what is causing the increase in ovarian cancer, and whether this is environmental or whether there is another biological issue to this.
So one of the simple things is, just as we get older, we get more cancers. The older we are, the more chance there is for a mutation to form, which is the driver of cancer, just because of time. And so we're victims of our own success to a degree. You know, medicine is keeping us alive a lot longer, and that means as well, unfortunately, we have more time for things to go wrong. And one of those things that can go wrong is cancer.
I'm always being asked by the people I work with in my ambassador role, so why is it that dementia is so common in women? I say it's quite simple. It's because we live longer. So we've got more time to accumulate it. Okay, so Sbba, were there any other things that you think in your community were particularly problematic, perhaps with the treatment and things? So I mean, do you feel that, for example, when you had that terrible, terrible disabling skin rash, that it was because it was so visible? Was that also a problem? Is it that, you know, when you actually are demonstrating side effects, does that stress your community more than it would do another community?
I think it's just the overall cancer conversation. Those are just like the little strands that come out from cancer, and, you know, the side effects are, there are a multitude. I mean, I had everything that the chemo could chuck at me, from, you know, the nausea, fatigue, constipation, diarrhea, every single thing, you name it, I got it. It's just the cancer, the C word. Forget everything else that comes after. Cancer is this huge grey cloud, where even now, if you speak to, you know, the slightly older generation, it is still considered a death sentence. You know, I had older members of the family asking my mum, oh, well, how long has she got? And you know, because in their minds, that's all cancer means. If you've got cancer diagnosis, it means death. And the other real difficulty thing within my community is language as well. Within the South Asian languages, there aren't words for certain parts of the body. So when I was trying to explain to my 84-year-old mum exactly what was wrong with me, there isn't a word for ovaries. So I couldn't even tell her. I had to physically print off a picture off Google and show her so she understood. And even if you talk about womb, the word for womb is bachedani, which means something you put a baby in. If you translate it, there isn't a word for breast. There's a word for chest, but there's no word for breast. So that the whole language around it is because the female form and female body parts is first and foremost always just looked in sexual terms, not in medical. And that's the flip that I want. I want these conversations to be normal. So we are having normalized conversations about female health.
Exactly. There's a lot of very interesting questions. We won't be able to get to all of them. But Neil, one of the things that the themes is coming up is, are there any more genetic tests that women can undertake? I mean, I know that's a very open-ended question, but to put in your and you're very good at giving us, I think, simple answers to complex problems. But what are the genetic tests we can do? One of our members of the audience is saying, you know, is there a BRCA equivalent for breast cancer, or for the ovarian, endometrial, and other cancers?
So thankfully, we're at a time now where there's a lot of work going on into understanding these inherited risks for cancers such as ovarian cancer and womb cancer. And there's amazing work going on by Professor Emma Crosby, based up in Manchester, and Professor Ranjit Manchanda, who's based down in London at Barts, looking at these really complicated issues around inherited risk. Now, there are some genes that we know that if you have a mutation within them, if the gene is faulty, then your risk of developing a womb cancer, for instance, is very high. And those genes are the genes associated with a condition called Lynch syndrome. And there's an amazing information leaflet on the Eva Peel's website all around Lynch syndrome. So if you want to learn a little bit more about Lynch syndrome, go to Eva Peel and have a look at their Lynch syndrome information. So those are genes that definitely, if there's something wrong with them, it's really straightforward. You've got a high risk of developing a womb cancer. And if you have a family history where there's lots of womb cancers, ovarian cancers, bowel cancers, maybe cancers of the tube that goes from the kidney to the bladder, the ureter as well, then that should start doctors thinking, do you have Lynch syndrome? And you can be referred to a service called the Clinical Genetic Service by your GP to have that properly investigated. There's also something called a PREM score, PREMM, which you can do yourself online, and that will give you a sort of risk of having Lynch syndrome. And, you know, again, if your score is high and you take that to your GP, that should, again, encourage them to refer you on to clinical genetic services. Now, we've also talked about BRCA, and BRCA is another one of these genes that we know if there's a fault within BRCA, then you've got a very high, well, a much increased lifetime risk of ovarian and breast cancer. And there's been some really good work done by NICE, led by Professor Ranjit Manchanda, on who should be referred in for testing for genes associated with ovarian cancer. And that's all published. It's on the NICE website. It's got a title something around the lines of familial history for ovarian cancer. It's got one of those nice titles that are quite long. But if you put in ovarian cancer familial risk, NICE, it will come up. And again, it's written really for healthcare professionals, but there are summaries in there that are more straightforward. And if you meet a certain threshold, so if you go to see your GP and you give them a family history that sounds to them to indicate that you could have one of these genes, you could have one of these inherited risks that increase your risk of having ovarian cancer, again, they should be referring you on to the Clinical Genetic Service for testing for that. And again, knowledge is power. So the thing about this is you've always had that fault in your genes. It's not something that we can fix. It's not something that's come. It's there. It's you. It's part of you. It's what makes you beautiful. But by knowing about it, there are lots of things we can do to reduce your risk of developing the cancers associated with it. So knowing about it means you can do something about it. So it's really important that if you think you've got one of those histories, if you think you've got something going on in the family, that you go and see your GP. And like I said, there's the Eva Peel information on Lynch, and there's the NICE guidance on ovarian cancer and genetic risk that you can read yourself and take to the GP if that would help, you know, formulate that conversation.
Yeah, that's really helpful. And I like you, the NICE website, I think, is an absolute treasure trove, isn't it, of stuff. And it's always evidence-based. It's not anecdote. It always has to be evidence-based. Now, I wanted to ask you also, Neil, when I went to medical school, we thought that cancers of the ovary came out of the ovary, but I think you're going to tell us that it's got a bit more sophisticated than that. So I wondered if you'd like to tell us the secret about where it really comes from.
So if the honest answer is we're still working on it. Give me a couple more weeks and I'll give you an answer, Dame Lesley. So yes, ovarian cancer. The first thing to say about ovarian cancer is that we use this nice term that says ovarian cancer, and everyone thinks ovary, and everyone thinks there's this one type of ovarian cancer. But as Sbba's already talked about, she has ovarian, which is low-grade serous, which is very different to the high-grade serous variant that's much more common, and the one that we more commonly treat within my service. There's another type called clear cell. There's a type called endometrioid, which looks a bit like the lining of the womb. There's lots of different, almost flavors of ice cream, if not to trivialize it, but lots of different ways in which ovarian cancer actually develops. And all of those cancers have a very unique pathway to getting to being a cancer. So they all take different routes to getting there. But what we have begun to understand is that actually, especially cancers associated with people with a BRCA mutation, what we think happens now is that there are changes in the cells within the tube. So the tube that goes from your womb sits close to your ovary and is the tube along which the egg will flow. Hopefully, if you're wanting to get pregnant, be fertilized, move down and into the womb. And that's really interesting, because if it's coming from your tubes, then we can potentially reduce your risk of developing an ovarian cancer, especially if you carry a BRCA mutation, by removing the tube, leaving the ovary, which hopefully should, would mitigate your risk of having a surgical menopause, which is awful. And this is work that Professor Ranjit Manchanda is doing, a study called Protector, where he's looking at, and other studies going on in Europe and America as well, looking at this question. If we remove the tube in these women, do we actually enable us to safely protect them from their variant of ovarian cancer, and mean that we can keep their ovaries in for a longer period of time, so the time in which they don't have their ovaries is much shorter? And the other thing just to say about that is that we've seen data that's quite convincing on population levels. So Scandinavia is very expensive, but it does have, if you want to go and buy a coffee there, it's extortionate, but it does have some of the best public health level data in the world. And if you look at women who have had their tubes removed for another reason, and if they go on to develop an ovarian cancer, that risk is greatly reduced. So there is definitely this story about the tube being the origin of the most common form of ovarian cancer. And the idea that if you wanted to, for instance, have surgery because you didn't want to have any more children, what we would now often offer women is actually removal of the tubes, because we know it can have a protective effect on their ovarian cancer risk in the future. But to mention that ovarian cancer risk for the general population is still low.
Yeah, exactly. Thank you. But I think it's so interesting the way things go in decades or eras, don't they? So I remember when I was doing sort of hysterectomies on a regular basis, we used to think we were being, very good to women if we took out the ovaries and the tubes, because then we'd cleared it all out. And then, of course, we didn't really understand about the long-term complications. Again, coming back to your point about we're living longer, of living without any ovarian function for very long periods of time. And then we thought, well, okay, we should be preserving the ovaries. And then, of course, we've got other problems that we didn't understand about the tubes at all. So it is interesting how we are all learning, but then there is the law of unintended consequences, as I often talk about, that sometimes you don't know why introducing a progress in one field that you're actually creating another problem. So coming back to you, Sbba, I mean, what are your real take-home messages for not just the women from South Asia, but for all women now? What do you think you've learnt what's been most useful? I mean, I know you've had a terrible time, but you're incredibly positive, like wanting to volunteer to come and do this with us today. So what do you think, what were the learning points for you that you really think have changed your attitude towards this?
I think there's probably two or three. One is that you do need to be more aware of your body, know you're normal. That is essential. And as Neil has said, if it doesn't feel right, do go and get it checked out. That is essential, because nobody knows your body better than you do. Don't feel or undervalue your judgment, and be persistent. Be persistent in asking for help and support. And if you are not finding it with one clinician, ask to see another doctor. But also, you know, knowledge is power. Educate yourself, become more aware, because as you say, as an aging population, there are more and more diseases that are becoming prevalent, and people are being diagnosed far younger as well. So, you know, educate yourself, be far more aware on women's health, and the Wellbeing of Women's website is absolutely fantastic for getting all of that information, because there are so many interesting subjects and topics that are discussed there. Know your normal, trust in yourself, be persistent, and be a drama queen if you need to be, but get yourself seen and get yourself checked out. And if you're not finding that you are being heard or listened to, go and speak to somebody else.
I think you're absolutely right, and it's one of my mantras all the time about, as you say, knowledge is power, and women have got an amazing role to play in helping them to navigate the system. And the other thing I would say as well is what I've always found really truly amazing about looking after women, and that's all I've ever done really, in my role as a gynecologist and obstetrician, that I'm always so impressed with when you explain to women what they need to do. Not only do they usually do it, but they go and publicize it. They tell everybody else they know about it. We're very generous as a sex or a gender, I think, in the way we want to talk about things and other people to benefit from it. So that's
absolutely
really...
and I think the other thing that I'd also like to add, Dame Lesley, is that we need to bring the men along with us. We need that allyship. We need our sons, our brothers, our husbands, our uncles. They all need to be on this journey with us, because they will have a life with a woman in their life, whether it is as a mother, a sister, a wife, a girlfriend. So they need to be able to be on this journey with us, and we need to bring them along.
Yes. I mean, I think that I really learned that when I started working with Dr. Nigat Arif, who, as you know, is a Muslim GP, and she's one of our Wellbeing of Women ambassadors. And we've done a lot of work together. But I remember the first time she introduced me to her father, who's an imam. And I think he thought I was the devil incarnate. And we're now best friends. And he invites me to go to his mosque to talk to the men as well as the women. So I think I've got a winner there. So, and you're quite right. We need allyship right across.
Absolutely.
Lovely. So we're moving towards the end, and I have to be prompt because otherwise I get into trouble from the Wellbeing of Women webinar team. So in the last few minutes, Neil, what are your sort of very last take-home messages for the women here about ovarian cancer? We were very keen to be supporting this on the Wellbeing of Women website, and so if you'd like to give us your last bon mots, shall we say, or starters for 10, or nuggets, golden nuggets, we'd really like them. And thank you so much to both of you for being so generous with your time and so frank and honest, because you can see from the questions that people are really, really impressed with what they've learned today. So over to you. I've given you a few moments to think that one through, haven't I?
So I would echo exactly what Sbba said, which is be empowered. If it's not right, get it checked out. And I'd also want to just finish on something positive, which is there is so much work going on, so much work, you know, work being funded by the Wellbeing of Women, work being funded by others to try and turn around what has been quite a sad story in ovarian cancer. We will get a test that will work and will detect the disease earlier. We will get better treatments that are less toxic. We will start to improve, as we have already seen, the outcomes that we see within ovarian cancer. And Sbba, I just want you to sort of, I think that it's your voice that we should hear at the end, so I'm going to shut up and you tell us what you want us to do as well.
For me, I think it just does go back to, you have to be able to be strong enough to self-advocate. Trust yourself, believe in yourself, and you know what your normal is. Don't let yourself be fobbed off, and you know, go and get that help, because the earlier we catch these things, the less invasive treatments are going to be, and there are so many different options in treatment pathways, you know, with the advancements in treatments, so the earlier it's caught, the easier things will be. So, you know, trust in yourself.
And just to echo that point that Neil made about we are making progress, although sometimes it may not feel as though we are. But I remember when I was a junior, that when I was doing gynecological cancer work, that we would open people up and that was it. We couldn't do anything. And there was no opportunity to go off then. And I have what's been a grueling time for you having the chemotherapy, but look at her now. She looks positively radiant, doesn't she?
Thank
So
you.
there was none of that option before. And so, yes, I do want to end on a positive note and say there is hope out there. And the more that you get involved with Wellbeing of Women and help us to raise money for research, the more geniuses like Neil and wonderful patients like Sbba are going to be able to, we're going to be able to fund them and make even more progress. Now, there's an enormous amount of clapping, well, metaphorical clapping going on the chat here. Everybody is talking about it's amazing, it's been wonderful, so easy to absorb. Neil, they said your way of talking about things. So I want just, all I have to do now is to thank you both very, very much for giving your time to Wellbeing of Women. And we would welcome you back with open arms at any time in the future. So thank you so much.
You.
Good luck, Neil, in your training. And Sbba, I'm going to get onto that Asian radio station to hear you. Hear you in full flood again. All right then.
Perfect.
So thank you, everybody, and bye-bye.
Bye-bye.